I'm now going to move on to another case, but a different venue. And if you're in the clot business, you understand clot can go anywhere. And so we're confronted with problems in any portion of the body, and that includes the visceral segment. So this particular case is a 71-year-old gentleman who had 2 days of worsening epigastric pain and a couple ER visits it took to get it figured out. He had some chronic kidney disease, some hyperlipidemia, and some reflux disease, but he ultimately had a CT angiogram which depicted a focal occlusion, an emboli, it appears, of the mid portion of the superior mesenteric artery. His white blood cell count was mildly elevated, as was his lactate, and his renal function was normal. And this was a case that one of my partners did months ago, but he went directly to the catheter lab for endovascular thrombectomy. So the AP and lateral views of the superior mesenteric artery are depicted here. This is a 7 French sheath that's into the SMA. And this case was obviously a little bit more favorable for this approach because you had some landing zone in which to place a sheath. The clot was actually more distal into the SMA than sometimes it is. But a sheath was able to be placed, and on this day, Penumbra, the 7 French device, was once again the first device to be utilized. It got a little bit more perfusion. Some of that thrombus has been removed, but this post Penumbra angiogram here shows we still have more distal occlusion of the artery, and there's significant residual thrombus left. So when one device is struggling, you choose another, and again, the Pounce thrombectomy catheter was utilized. So the catheter is advanced past all of the residual thrombus well into the distal part of the SMA, still the primary trunk. But the baskets were deployed in this region and withdrawn, and it was successful in removing all of the residual thrombus from the more distal SMA. And we now have 6-month follow-up on this gentleman by duplex ultrasound. The SMA is widely patent. Thank you.